Buongiorno.
Buongiorno. Bonjour. Guten Tag. Ça va? Okay. So I've done all my language. Thank you very much, Carl, for the great introduction. And it's a pleasure to be among friends. And it's a pleasure to see that somebody woke up early. So there is a pretty good turnout after yesterday partying night. So I am very honored to be here and very pleased to be able to talk about my favorite topic, which is the POEM procedure for achalasia. And I have nothing to disclose. So POEM is now 10 years old, and we are starting to accumulating some data, solid data about this procedure, who definitely was thought to be one of the most outrageous and dangerous procedures 10 years ago. And I love to cite my very good friend, dear friend, Lynn Swanstrom, who said, God put the esophagus in the chest to hide it from surgeons. Well, I think that we really went from fear to knowledge, and there are today more than 400 publications on POEM that really allow us to understand the literature and the data on this procedure. But everything started really with a man, a pioneer and a master, Aro Inoue, who really had the knowledge to push this procedure through. And he thought that with his experience in ESD, it was safe to perforate willingly the esophagus to tunnel all the way down to perform a myotomy. And the beauty of it was that it was just taking what was needed, so there was no collateral damage. And he was right, because now in 2018, just last year, we have a lot of centers that perform POEM, and we have at least 4 centers that perform more than 200 cases. And achalasia is not such a rare disease if we look at these data. We have more than 7,000 cases worldwide, and we use this technique to treat both hypertensive disorders in addition to achalasia. And now definitely it has become part of the standard of care in the centers that have the skills and the diagnostic ability to treat achalasia. 25% of the achalasia patients are treated today with the POEM procedures. There is good evidence of safety and solid data on efficacy of POEM over the publication that have been published so far in the literature, and also evidence, starting evidence, growing evidence of long-term success. And definitely patients want it, they prefer it. One of the problems of the randomized comparative trial was to enroll patients for laparoscopic hilar myotomy. That was the problem at our institution and the problem that many institutions had to complete these trials. What about the results? Results were very well analyzed, because this procedure was extremely scrutinized, because they thought, I lost my slides, but I can keep talking, no problem. Very scrutinized because it was thought to be an extreme procedure. So we have very good results, both in terms of physiology, lowering of the high pressure zone at the level of the LES, but also in terms of providing relief, mainly from dysphagia, with an echo score that is inferior to 3. Many authors confirm these results short-term, but there is growing evidence also of long-term data with a mean efficacy of about 80%, going all the way up to 100% for dysphagia. Longevity, 2 years data confirmed that still there is an efficacy at about 80%. There is a little bit of fading effect, as you would have for a laparoscopic hilar myotomy. And the longest follow-up that comes from the group in Portland shows that at 5 years, you still have 83% of relief for patients presenting with achalasia, and a higher efficacy for patients presenting with DES. What about a comparison with hilar? Very similar results in terms of dysphagia relief. The big question is what happens in terms of reflux. And if I take one of the largest series comparing laparoscopic hilar myotomy with fundoplication and the POEM, which comes from Liz Swanstrom in Portland and the Portland group, you see that POEM has a shorter operative time, has less complication, is faster in terms of going back to normal activity, has a more profound relief of dysphagia, but does have a higher reflux rate. Although what they commented in their paper, which is very true and is exactly what we are observing, is that reflux is much higher at the beginning of the experience, and then it can be tuned down when you learn how to perform the procedure and you shorten the myotomy, taking out only what is needed. But you still can have up to 40% of reflux. The problem is that you cannot rely on symptoms, and in the literature you find everything in terms of monitoring GERD after POEM. What we do know is that when you measure it objectively, especially with endoscopy, looking for esophagitis, and when you do pH impedance or just pH, you see that has a higher there is a higher rate of reflux after POEM procedures. Although this, once again, is very heterogeneously dispersed in the literature, and there is a lack of a standardization of collection of this data. If we try to figure out what are the predisposing factors to develop reflux after POEM, maybe the length of the myotomy, the fact that some authors perform a full-thickness myotomy, the duration of the procedure, which is mainly related to the learning curve and to the difficult operation. What we do know is symptoms are absolutely not reliable in monitoring reflux. So those patients really need to be studied with functional testing and need to be scoped. We scope them systematically at 6 months and 1 year, and at 6 months we repeat function testing, pH impedance testing, in order to really check if the patient has reflux. And in that case, we put them on PPI. And this is the eternal debate that we also faced in standard laparoscopic Heller myotomy. So what is the good compromise between a complete myotomy and the rate of reflux? If you're less aggressive, you might jeopardize the outcome of the operation, have more dysphagia. If you do too little, you might give the patient reflux. So there is definitely a need for objective intraoperative assessment and for very thorough preoperative monitoring on these patients. We can't really tailor the myotomy. Most people don't do it, though. So that is the main problem. And when you look in the literature, you find myotomies that are 15 centimeters length, 5 centimeters length, totally arbitrary decision on how long should the myotomy be. And today you have a catheter that's called the endoflip that allows to perform impedance planimetry. Impedance planimetry is perfect for this operation because it allows you to understand how much you have to take, how long is that high pressure zone, how well you have to release the pressure in order to achieve a good result without compromising the anti-reflux barrier. And if you do so, then your reflux rate can go down. There are some advanced indications that are comfortable today with this technique, which include salvage case after failed Heller myotomy, laparoscopic or open, sigmoid esophagus, end-stage achalasia, spastic disease. Pediatric cases are growing. And what we can see is that it is totally doable to perform a POEM procedure after a Heller procedure. It's technically more challenging, but the beauty of it is that if you're going endoscopically after an open or a laparoscopic procedure, you can go posterior, and you have a virgin territory. So that is doable, and what we have seen is that also has better results than a standard redo laparoscopic Heller myotomy for a recurrent disease. And can we do it again? If POEM fails, can we go back and perform another POEM? Yes, we can, and the results are pretty acceptable. Of course, the efficacy is not comparable to a primary procedure in a patient who did not have prior treatment, but they are still very good, and most of all, is safe. Should we perform POEM to every single patient? Definitely not. There are some contraindications. This is a procedure that is pretty demanding for the anesthesia team too. It has to be performed under general anesthesia, so patients who are contraindicated for general anesthesia should not undergo this procedure. If you have a hiatal hernia or any other predisposing factors for GERD, I think that the patient would be best served with a standard hiatal hernia repair, Heller myotomy, and a partial fundoplication, posterior or anterior. If there is GERD, I would opt for a posterior fundoplication. We can discuss that later, but still, laparoscopic Heller myotomy is an operation that is not dead, is still there, and is the best operation for some indication. POEM is not easy. You do need to train, and you need to be mentored in your first cases. This is extremely important, especially if you don't have any ESD or resection skills. It's something that might be pretty hard to learn. It doesn't require just skills, it requires a profound knowledge of the disease, which means that you do have to understand functional esophageal testing, and you have to understand what you're doing when you're cutting the muscle, and understand how you can monitor the procedure intraoperatively. Has to also be performed by a team that is a mixed team or is a surgical team, because if things go wrong, you have to react quickly, and you have to do so in an operative environment that is fully equipped. And just a few perspectives, the most dangerous procedure that derived from nodes, at least this was thought at the beginning, really led the way to other submucosal tunneling procedures, which go from a different way to perform a pylorus myotomy, cracomyotomy, a different way to perform Hirschsprung, to tackle Hirschsprung disease, and also to implant bariatric devices, take muscular biopsy for functional diseases. So it led the way to the third space, which is the submucosal space. So in conclusion, and I hope I made it with my time, POEM is a safe procedure, it's very effective, the effects are durable. We do know that the rate of GERD should be investigated, and we do have a higher rate of GERD than a laparoscopic helermyotomy with a fundoplication. Learning esophageal function testing and performing intraoperative monitoring is fundamental. It's key to standardize the procedure because it's not standardized yet. We do know that patients need monitoring and need follow-up in terms of endoscopy and pH monitoring, because symptoms are not a good indicator of GERD. It is a better operation, at least in my opinion, and that's what's shown in the literature for a redo case if the patient had prior helermyotomy. And results are good, but we're still learning. Thank you very much.